kidney stones are not uncommon in HIV patients. The drug-related kidney stones are a very uncommon subset of that disease expression. Okay? Any questions about HIV before we move on to TMA? Okay, we're making good time then. All right, so then let's talk about some common features that one can see with the TMAs before we talk about individual TMAs. And we're going to talk about, as we talk about individual TMAs, let's highlight the road ahead. So typical hemolytic uremic syndrome, so that's after the intestinal infection with E. coli, for instance, or shigellosis. So that's typical HUS. Then we're talking about atypical HUS, which, by the way, will further elucidate as we talk about disordered complement when we talk about MPGN. MPGN is another, which will be Friday, is another condition in which disordered complement underpins its pathogenesis in many cases. Okay, so typical HUS, atypical HUS, and then TTP as another one. And then I think we're talking about scleroderma as well. Yeah, so scleroderma, renal crisis. Others would include things like malignant hypertension, certainly is one of the most common TMAs that you're going to see. And then, things like antiphospholipid antibody syndrome or drug-induced TMAs we're going to capture under this final other thrombotic microangiopathy. Okay, so you see the mile markers ahead. Let's then first talk about features of all of these thrombotic microangiopathies. We're going to see platelet-rich thrombi in multiple vascular beds, okay? Intravascular hemolysis is present in all of these conditions. Haptoglobin is a very sensitive test for the presence of intravascular hemolysis. Haptoglobin goes down very quickly with free heme circulating in response to mild degrees of hemolysis. Even with blood transfusions, haptoglobin can come down shortly after a blood transfusion. So it's a very sensitive test for free heme circulating, so intravascular hemolysis. And then, of course, you're seeing schistocytes as well. Now, often patients with thrombotic microangiopathy have accelerating hypertension, and that makes sense pathogenically because they have these microthrombi presence in some of the small vessels, including the afferent arteriole. And if they have this microthrombi impairing the perfusion of the nephron units that are downstream of that, you would predictably get increases in renin. So hyperreninemic, hyperaldosteronism would be characteristic for TMA. And that hyperreninemia would drive angiotensin as well as aldosterone, resulting in an elevation in blood pressure very commonly. So that's why scleroderma renal crisis, typical and atypical HUS often have increases in blood pressure. And, we had a patient, I think some of you recently took care of her. She was a lupus patient who had TMA as well as alveolar hemorrhage, recently progressed to kidney failure and was initiated on PD within the last month. She was a acute urgent start PD, so I think some of you have had experience with this patient. If you look back at her history, when she had this, and she was on, she had severe hypertension on minoxidil, on aldosterone antagonists, on nifedipine, hydralazine, Coreg, all at maximum doses. You can see that she had extremely high renins and aldo levels consistent with this pathogenesis. Okay, renal biopsy again reveals these fibrin thrombi that can be present in the glomerular tuft. Here we have an H&E stain. Some of these have these sort of kind of well, how did I guess I jump to a different part of our document. Sorry, let me find this again. You can see these kind of glassy appearance to this fibrin microthrombi in the glomerular tuft. You can see again, it's a little bit of a different hue than the surrounding matrix in this H&E stain. Sometimes it has this bluish appearance. That is this mucoid degeneration is this bluish appearance that you can see in the vessel wall. Okay. And then you can see in the more chronic phase of this TMA, this remodeling that happens in the vascular wall where layers of basement membrane have this disordered appearance and so-called onion skinning appearance of a more chronic phase of the TMA. Okay, so let's then move to the individual diseases, starting with typical HUS. Pathogenesis involves a Shiga toxin that causes a dysfunction of the endothelial cell as well as platelets. That dysfunction results in platelet thrombi, platelet-rich thrombi, consumption of platelets, and then the red cell destruction that occurs downstream. Usually, again, this is an E. coli that drives this, the classic of which is this O157H7 form or variant of E. coli. There is often leukocytosis that's present, and there's a correlation of this leukocytosis with prognosis, suggesting that neutrophil activation is another part of the pathogenesis of typical HUS. HUS often occurs a couple of weeks after bloody diarrhea. This E. coli can be shed in the stool for weeks after the original infection. There's significant occurrence of neurologic symptoms in as much as a third of patients. You can also see other organ dysfunction, including pancreatitis. Now, thrombocytopenia is usually severe, but is less severe than TTP. TTP often has lower platelet counts, and we'll see that when we're describing the plasmic score when we talk about TTP, a risk score that predicts the likelihood of dealing with TTP. That'll filter to that part of our conversation that's forthcoming. And then children classically are described with this HUS, and we have published reports of a typical HUS estimating the risk of ESRD in about 10% of children. Okay, certainly this can happen in adults as well. The data is more rich in the pediatric literature. Management is typically supportive care. We actually espouse avoiding antibiotics because there is perhaps an increase in Shiga toxin release and therefore an acceleration of disease when you have and when you use antibiotics in the setting of typical HUS. Now, if you are septic, then you're going to treat them with antibiotics. But usually E. coli enteritis is self-limited. You, of course, avoid antidiarrheals, and you let them, sort of shed the bacteria in the stool and provide supportive care like IV fluids to such that they can avoid volume depletion and acute kidney injury from a second mechanism or a second hit. Okay. Moving on, typical or atypical HUS is a disease of complement regulation. Okay, and again, we'll highlight some of that in our conversation with um, MPGN, where we'll go over this pathway of complement activation with a focus on the alternative pathway of complement activation. So MPGN, dense deposit disease, and C3GN, subsets of MPGN, uh, the result of disordered alternative pathway of complement regulation. Atypical HUS is similarly the result of disordered regulation of the alternative pathway of complement activation. You can see in C3GN, dense deposit disease, and atypical HUS, varying degrees of C3 depression, and that is because C3 is consumed from the activation or disordered regulation of, or unopposed activation of the alternative pathway. Okay, so C3 is not consistently depressed in C3GN or dense deposit disease or atypical HUS, but it is described. C4 in these conditions would not be depressed because C4 is consumed through activation of the classical pathway of complement activation. You can have mutations in various regulatory proteins, the most classic of which is complement factor H, that can cause atypical HUS or C3GN or dense deposit disease. So, and then there's can be disorders in factor B, other multiple components of the alternative pathway of complement regulation. Okay. So often there's an inciting event, classic of which is infection or pregnancy. Remember, you have ongoing complement activation through so-called tickover activation. So the alternative pathway of complement is constantly in a state of activation. You avoid catastrophe by putting that activation in check. So you have these inhibitors of unopposed activation. And so often you'll have an infection that tilts the balance of activation and inhibitors in favor of acceleration. Pregnancy is another instance in which complement regulation favors activation over inhibition. Okay, so these are often inciting events in a patient who has atypical HUS. That often can add for diagnostic uncertainty because pregnancy is another uh, context in which you can have TTP. So Adam's TS13 levels go down in normal pregnancy. So that can be an inciting effect of TT or inciting event for TTP. Pregnancy can also cause thrombocytopenia and hypertension through other mechanisms, such as severe preeclampsia or the full-blown HELP syndrome. So pregnancy is a classic scenario in which there is thrombocytopenia with acute kidney injury with a number of diagnostic possibilities, including atypical HUS and TTP. We talked about that, believe it or not, in our pregnancy discussion, so I'm not going to scroll back. I'll have you reference that discussion and your notes from that prior conversation. Okay, so I'm just highlighting that here in this discussion. Let's end on pathogenesis and then pick this up on Friday. So again, inciting events often are present, such as infection or pregnancy, and then that may occur in this background of inherited deficiencies in complement regulation. You can also have an acquired deficiency in complement regulation, such as the production of an autoantibody that inhibits complement factor H, for instance. Okay, so that's the sort of broad strokes of disease pathogenesis of atypical HUS. First hit that sets the dominoes in motion, and this background of either inherited or acquired deficiency in complement regulation. You can have, again, a number of elements of the alternative pathway that can be dysfunctional. Factor H is the classic one. And this takes a little bit of discussion. Remember, let's use complement factor H as a standard for making this point. People have described C-terminal mutations of factor H being associated, forgive me, I don't remember which, either C3GN or atypical HUS, versus N-terminal mutations of factor H, which are associated with the opposite. Okay, what is this story? How does this play out? Well, when you have mutations in C-terminal versus N-terminal portions of this peptide or this protein, it either creates altered complement regulation in the fluid phase or in the cell membrane bound complement regulatory pathways. So you regulate complement locally at the cell surface, and you also regulate complement in circulation in so-called fluid phase. When you have disordered regulation at the cell surface, that's when this primary event of endothelial dysfunction can occur and then activate platelets and result in HUS. When I have disordered complement regulation in fluid phase, that's when you can generate some of these immune uh, um, deposits in the glomerulus, okay, resulting in C3GN or dense deposit disease, okay? So again, that's part of an interesting story as we began to learn about complement regulation, and gives a little bit of explanation why certain patients with mutations in factor H develop atypical HUS, whereas other patients will develop C3GN or dense deposit disease. Okay.